Hello, everyone. I'm going to let everybody trickle in. It always takes a minute. So happy to see a good crowd, even though I can't see you, but still happy you're all here with us. I should probably start because we have a lot to get through in an hour. And first and foremost, good afternoon, everyone. Welcome to our 5th annual Gynecologic Cancer webinar series. 5th annual is a really big deal, and we have an amazing presenter kicking us off. I'm Rachel Rosen Simpson. I'm the program manager at the Breast Cancer Coalition. I'm so glad you could all join us to learn more about what happens after active treatment for gynecologic cancers with Dr. Sajeena Geevarghese. We are grateful to the Saunders Foundation that supports coalition educational offerings like this series. So before we begin today's presentation, I have a few upcoming events and housekeeping announcements to share. Our PALS mentorship training is coming up on Saturday, September 13th from 9 to 3, and we'd love to be able to better support our incoming gynecologic cancer survivors by connecting them with peer mentors. So if you are interested in training to be a mentor, please contact the coalition and we'll figure it out. In terms of housekeeping, if you need closed captioning, it's always available by clicking the little CC button at the bottom of your Zoom screen. I will facilitate a question and answer session following the presentation. So as you have questions throughout the presentation, please type them into the chat function, and I'll continue to compile them as the presentation unfolds. I'll share them at the end with our amazing presenter today, and we will answer as many as possible before we try to wrap up by noon to be mindful of everyone's time. And just a disclaimer that our presenters cannot give any specific medical advice without knowing each of you during this short time we have together. So if you could try to keep your questions as broad and inclusive of others as possible, that would be much appreciated. If you want to watch this presentation again, or for the first time and share it with somebody else, it's being recorded and will be added to our webinar library as well as uploaded to our YouTube channel, and it's publicly searchable now. So I'll drop both the links. I did drop the links into the chat, but I'll drop them again just in case. And the links to register for our future webinars in these weekly Wednesday webinar series for your convenience. And lastly, there will be a survey that pops up on your browser whenever you leave the webinar, and we do utilize that anonymous feedback when planning our program offerings. So please complete the survey if you have time for 10 questions, just quick survey, I promise. Okay, so today's webinar features a special guest and a friend of the Breast Cancer Coalition, Dr. Sajeena Geevarghese, often fondly referred to as Dr. G. Dr. G is a native of Chattanooga, Tennessee, and has board certifications in obstetrics and gynecology, as well as gynecologic oncology. Dr. Geevarghese received her medical degree from Johns Hopkins University in Baltimore, Maryland, and completed her residency at Washington University in St. Louis, Missouri. And prior to joining the Rochester Regional Health as the Executive Medical Director for Gynecologic Oncology, Dr. Geevarghese completed her fellowship in gynecologic oncology at the University of Minnesota in Minneapolis and served as associate professor and director of medical education for gynecologic oncology at the University of Rochester Medical Center. In 2022, Dr. Geevarghese was appointed Executive Medical Director for Rochester Regional Health Gynecologic Oncology, and in this role, she leads strategic, clinical, and operational priorities for the Department of Gynecologic Oncology, in addition to providing expert care to all of her patients. She is beloved, and we are grateful that she could make time to be with us today. So without further ado, take it away, Dr. G.
All right. Thank you so much, Rachel, for the opportunity. Can you see my slides, Rachel? I think so, right? We're good?
Looks great to me.
Perfect. Perfect. So good afternoon, everyone. Hello, my name is Sajeena Geevarghese. I've been in the Rochester area since 2009, so almost 20 years. It's really a privilege to speak today and really to speak out of my experience of walking with patients for almost 20 years to answer this question: what happens next? What is life like after active treatment? So I love this quote from Maya Angelou. My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style. And really, that's what we're talking about. We're talking about thriving. Um, that's what my hope for all of you is. My wish is to thrive after cancer treatment, to thrive during cancer treatment, but that's quite challenging. But then afterwards, to pivot to figuring out how to optimize quality of life and how truly to thrive, as Maya Angelou is talking about. So, little disclaimer, and Rachel talked about it just a bit. This is really general advice. I don't know the specifics of your situation. So, the strategies and treatments that I'm going to name may or may not be helpful for your specific situation. So, please, I encourage you, talk to your oncology team, talk to your primary care provider before initiating any steps. Really, this is more just generic who has walked with women, but it's not really specific necessarily to your situation. But just get too much on my soapbox, but you'll see I'm a bit passionate about a few things. All right, this is the outline to my talk. We're going to maintenance therapies. We've come a long way where we actually have availability of maintenance therapies, and that wasn't the case just a few years ago. Then we're going to talk about survivorship and surveillance. Then I want to touch about some key symptoms that patients face after cancer, cancer-related fatigue, chemo brain, peripheral neuropathy. We're going to briefly touch about sexual health, nutrition. And I know that there's some speakers coming in the next few weeks that are going to talk about sexual health and pelvic physical therapy. I'm going to briefly touch on that, but I'm so excited, Rachel, that they're going to be coming. Those are the next talks. And then a discussion about lymphedema, which I don't really touch on, but it is a key topic that affects many of our survivors. So very appreciative to the Breast Cancer Coalition group for coming and actually initiating talks on these really important topics. But we're going to brush on these topics generically and some specifics, but looking forward to hearing Rachel from the experts who are going to speak over the next few weeks. So, gynecologic cancers, got to take a step back. What are the cancers that I treat? So, the gynecologic cancers, let's go over anatomy. So, this is a diagram of the uterus, and the uterus is the top portion, it's right above the cervix. You have the vagina here, and then the vulva. And out of the cornua of the uterus, you can see fallopian tubes and then the ovaries. So this is quite an artistic diagram. I often have patients ask me if I remove their cervix, uterus, fallopian tubes, are their ovaries just going to be floating in space? No, this is just an artistic diagram. There's a ton of ligaments here, vasculature, vessels that are going to each of these. And so please know, I just thought I'd throw that out there, that if your ovaries remain in place, they actually are in place, attached to the important ligaments that they've always been attached to. But to just go over the anatomy, the lining of the uterus is called the endometrium. That's the most common cancer that we treat. And so that is part of the uterus. And then fallopian tubes, we discussed, and ovaries. And so the treatment or management of fallopian tube cancer and ovarian cancer is similar. In fact, we also include primary peritoneal cancer as a gynecologic oncology as a cancer that I treat. And the cells that coat the lining of the ovary or line the ovary are the same cells that line the peritoneum. So if you think about your body, similar to that of a pool and how there's a pool liner, there's actually a lining to our abdomen, and that's called the peritoneum. And so cancers can develop of that lining called primary peritoneal cancer. And those cells are the same cells that coat the ovary. compose the fallopian tube. And so those cancers are all treated similarly, oftentimes with surgery followed by chemotherapy or chemotherapy, surgery, and more chemotherapy. The treatment of ovarian, fallopian tube, and primary peritoneal cancers is very different than uterine cancers. Primarily endometrial cancers, usually there's surgery first, and then followed by chemotherapy, plus or minus radiation, depending upon the stage. That's going to be very different than cervix cancer. So, cervical cancer or the cervix is at the bottom portion of the uterus. Cervical cancers, unless they are diagnosed super crazy early, usually would benefit from radiation. If diagnosed early, that's when there may be a role for surgery. But cervical cancers are very sensitive to radiation, and oftentimes, if locally advanced, will also give the addition of chemotherapy, low dose, and add immunotherapy, which we're going to touch on. So you can see that the treatment of these cancers is very different depending upon what organ they're originating from. Vaginal cancers, so cancers of the vagina that's below the cervix. So when we place a speculum and take a look, we're usually looking at the vagina and the cervix. The vagina, cancers of the vagina often are treated with radiation. And the vulva is the outside portion. And so you have the labia, the lips of the vulva. Those cancers are often treated with surgery primarily, but can also require radiation, sometimes a low dose of chemotherapy as well. So you can see just what kind of variety in the management of these cancers, even though the organs are right next to each other. Some of them involve chemotherapy, some of them involve surgery primarily, some of them involved radiation. And so there's quite the mix. We'll go on to the next slide because that also takes into play maintenance therapies. So back in the day, as in when I was training and soon after even fellowship, we didn't have maintenance therapies. In fact, we often would try to give patients more chemotherapy after their cancer diagnosis. And what we would find is it didn't decrease the chance that the cancer was coming back. In fact, it was associated with more toxicity. So maintenance therapies, particularly with chemotherapy, fell out of favor until we started to get more biologic agents. And so now patients can undergo 6 cycles of chemotherapy or chemoradiation. And back in the day, that was it. We were done. And then it was watchful waiting. Now the horizon of care has really expanded with these targeted therapies, and we really are targeting how these cancers develop. So in the realm of advanced endometrial cancer, patients undergo chemotherapy and immunotherapy, and then often that's followed by immunotherapy alone for a couple of years. And what is immunotherapy? So pembrolizumab, I'm sure you've seen the commercials, Keytruda, or dostarlimab. These agents are immunotherapy. What that means is it stimulates the immune system to fight the cancer. What cancers can do is they can evade the immune system, so the immune system has no idea what's happening, and then cancers can progress. But what these agents do is essentially take the blindfold off of the immune system, and now the immune system recognizes the cancer and can target the cancer and kill the cancer. The side effects of immunotherapy are very different than chemotherapy. With immunotherapy, the side effects can include actually that the immune system fights itself. And so patients can develop inflammation of any part of their organs systems. So often patients can develop diarrhea or a colitis, inflammation of the colon. They can develop inflammation of the skin or a rash, a dermatitis, inflammation of the thyroid called a thyroiditis. And so you get the idea. You can develop an itis of any organ system of the body. And those are the side effects of immunotherapy. And what we do in that situation is just give a course of steroids. It calms the immune system down. And then oftentimes we can restart. And so endometrial cancer, the treatment of endometrial cancer has really drastically changed with the introduction of immunotherapy. And this will continue after the 6 cycles of chemotherapy. Patients can continue to be on immunotherapy initially every 3 weeks, and then it can move to every 6 weeks. And usually during that time, patients have good quality of life, but we have to be aware of these symptoms that can develop. For ovarian, fallopian tube, and we talked about primary peritoneal cancer, there's a role of bevacizumab maintenance or Avastin, also PARP inhibitors. So what bevacizumab is, or Avastin, those are VEGF inhibitors. Essentially, how they work is they target the new blood vessels that cancers recruit to itself, thereby killing those vessels and then causing the cancer to shrink. And so if a patient is started on Avastin or bevacizumab during their chemotherapy, we can continue that for several months down the line. And so patients can continue to undergo bevacizumab maintenance. The side effects of Bev are different. They're more vascular, so they increase the risk of hypertension, which usually can be well controlled with blood pressure medications. They increase the risk of blood clots, so more vascular type of complications. So none of these maintenance therapies are without risk. They all have side effects associated, and that's when we think that more, in patients with advanced disease who are at higher risk of cancers coming back, that's where maintenance therapies really play a role. PARP inhibitors are targeted therapy against the BRCA gene mutation or BRCA expressed by the tumor. So in patients with more advanced disease, stage 2 through 4, those patients benefit if they have the germline mutation, meaning the patient herself has the DNA mutation, or if the tumor, the cancer, expresses a BRCA mutation, we can target that with PARP inhibitors. But there are side effects to PARP inhibitors. But these patients then can undergo PARP maintenance for a couple of years. And then we move to cervix cancer. So remember, I talked about that with cervical cancer, most of these patients, it's not really caught that early. It's usually caught a little bit later, and those patients are undergoing chemoradiation. If they express PDL, certain types of squamous cell carcinomas, actually majority, would benefit from immunotherapy. And so that would occur. They'd receive it while they're receiving chemoradiation, but then you can continue with the Keytruda as maintenance therapy to decrease the chance of the cervix cancer coming back. In patients with metastatic cervical cancer, those are patients who are not undergoing radiation, but full dose chemotherapy in addition to bevacizumab, in addition to immunotherapy. Then the bevacizumab and the pembrolizumab can continue as maintenance therapy to decrease the chance of the cancer coming back. So we have these maintenance therapies, and some patients, depending upon their cancer and how advanced, may benefit from them. But we really have to think about the benefit versus risk ratio because these are all associated with risk. And so you do have to be managed closely by your oncology team. So survivorship, it's the long road ahead. The focus becomes long-term health and wellness. And really follow-up care and surveillance is a crucial portion of that. What I mean by follow-up care is for all patients who are diagnosed with a gynecologic cancer and they're in remission. And what I mean by that is a CAT scan, an exam has shown that there's no evidence of disease. Then we move into surveillance mode. And it's really like a checkup mode. And so patients undergo exams, thorough history and physical exam every 3 to 4 months for 2 years. And then those exams space out to every 6 months for an additional 3 years. And the reason for that is it's in those first 2 years that patients are highest risk of the cancer coming back. And so we monitor very closely. What are these checkups composed of? Thorough history and physical, okay? Pelvic exams, rectal exams. The one thing about gynecologic cancers is that they often tend to recur locally, close to where they started. And so on pelvic exam, we can feel for nodularity. We can feel for a mass. We can feel for a change that's occurred that may indicate that the cancer has recurred. And so that's why there's real utility in doing a pelvic exam. I know they're uncomfortable. But hopefully in the right hands, they shouldn't be too uncomfortable because the key thing is relaxing and making sure that you're at the lowest point of the bed and that your bottom is a little bit off of the bed. Just little information there. Um, but there is utility in the pelvic exam. And I'm not talking about a pap smear. A pap smear is just a brush. That utility of that during routine surveillance visits for ovarian cancer, uterine cancer, there is no utility in the pap smear. So I'm not talking about cytology. I'm talking about actually visualization, palpation. Those are very crucial to monitoring to see from a physical exam standpoint, has a cancer recurred? Sometimes patients have tumor markers that are elevated at the time of diagnosis, and so we can monitor those markers in the surveillance period. It's going to be one of those situations where you get your blood drawn several days prior to the exam so that it can be, its value can also be incorporated in the bigger picture of how you're doing, what your exam feels like, and then also being reassured by the CA-125. So that's a tumor marker primarily for epithelial ovarian cancer. It can be utilized in advanced uterine cancer, but only really if it's been elevated from the get-go. With patients with uterine sarcomas, when they recur, they tend not to recur locally. And so that's where there's a real role for routine CAT scans. Otherwise, for the other diagnoses, cancer diagnoses, routine CAT scans are not recommended because of the radiation that's associated and because oftentimes these recur locally or there's symptoms associated. And so we're able to catch earlier and we have a lot more options. With uterine sarcomas, that's not really the case. And so routine CAT scans are part of the management. So what about these checkups? What I tell patients is you're going to look out for certain symptoms of the cancer coming back. Vaginal bleeding, vaginal discharge, changes in bowel or bladder habits, pain that persists. And so what we're talking about is a change that occurs that persists for a couple of weeks, right? So it's not going away, it might be even getting worse. That's when you're going to call. We don't want it to go beyond that, right? Because that would involve suffering. But at the same time, if you have a change in bowel habits, let's say you have some loose stool one episode and maybe you ate something funny, maybe something didn't quite agree with you, that's going to be different. That's not what we're talking about. We're talking about a change that occurs that persists for a couple of weeks. Notify your oncology provider. Okay. Those could be symptoms that the cancer is coming back. It is super important that you notify your oncology provider because sometimes if primary care physicians are notified first, their thought isn't going to be, first, I need to rule out cancer. And for us, we want to make sure that the cancer hasn't come back. So that's often going to be, we're going to call you in, we're going to examine you, we're going to see what the history is, and we may go ahead and order a CAT scan just to get a better sense of what's really going on. But I want you to always engage your oncology provider, even when you're in this checkup mode. You start with us. And if we feel that it's not related to cancer, then we'll direct you to your primary care physician. But I find, and I think my team finds, that that's the safest approach is when the change occurs and it persists to actually contact us so we can make sure that if it is cancer related, we can get things going, we can do imaging, we can figure out and manage things appropriately. I think one of my biggest pet peeves, and it's not really a pet peeve, it makes me really sad, is when patients come for these checkup exams and they say, you know what, doctor, I've had this pain and it's been getting worse for 2 months. I think that is always so hard for me because I'm like, why didn't you call us? Why didn't you notify us? So please know from an oncology standpoint, we want to know you're not bothering us. And if a change occurs and it persists, reach out. If you don't want to make a phone call, reasonable, mic hear us, right? Message us. So then we can be proactive on your behalf, advocate for your behalf. But these checkups really are meant that you feel great, you have no symptoms, life is good, and you're coming for a checkup. If you're having symptoms, we need to know that ahead of time, ideally, and not to wait. I guess that's what I'm saying is some patients will say, oh, I have a checkup next month. Yes, I'm having this pain. I'm just going to wait until next month because of some convenience. No, please don't do that. Call us. Okay. So I think I may get off my soapbox only to get back on for the next slide. Um, but that's key is a real focus on care, surveillance. And this is about your long-term health and wellness. So I wanted to also take some time because we don't talk about this, the psychology of survivorship. And this is really out of my experience for 20, almost 20 years, right? So if you think about diagnosis of cancer and how it just is utterly shocking, and then suddenly you're on this go mode, right? Got to do. And so now we're talking about surgery. Now we're talking about chemotherapy. And then within chemotherapy, now we're talking about visits, right? Blood work. And then you have your oncology visit with your provider and then chemotherapy. And then it repeats the next 3 weeks, like it just keeps repeating. And so on the calendar there's always something, there's always another appointment, there's a constant reminder, right? Go, things are being done, very, very active, very sometimes chaotic. If you're undergoing chemoradiation, right, it's radiation every day, so every day, boom, 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 right? You're seeing a provider, you're constantly reminded, you're just there, you're constantly doing. And so during treatment you can get this incredibly hectic schedule. And then what happens after treatment when that CAT scan says that everything, the cancer is gone, that you are in remission, and now it's time to focus on checkups and, restore sort of normal life. What I find is that for some, and remember, this is a time where there's now less appointments, right? Now the appointments aren't every 3 weeks, they're every 3 months. And so for some, you return to a new normal, and you're able to focus on life that has, been neglected. For others, it's incredibly unnerving. Anxiety worsens because every moment is that much closer to the next recurrence, the next shoe dropping. There's this constant fear of recurrence, and that's the most common concern for survivors. And what that ends up manifesting is this persistent anxiety. So I would take a moment to recognize that, because this is when I find that patients really get lost and that feelings of stress, depression, and anxiety not only are common, but they can become debilitating. Gynecologic cancers often require removal of the gynecologic organs. So removal of the cervix, uterus, fallopian tubes, and ovaries. Some women no longer feel like women after these have been removed, and they struggle with body image. Chemotherapy often results in the loss of hair, right? And our hair is what often identifies us. And so these treatment-related changes to the body can impact self-esteem. They can impact our relationship, our most core relationships with others. And so recognizing the psychology behind this time of survivorship. Also, relationships change, right? Mom, who's always been the superhero, mom has always been the one that has been there for everybody else. Mom's always the one who's managed things in control, like, has everything together. Now, mom is the patient, and other people have to support mom. And so relationship dynamics change. And recognizing all of these changes that have taken place is important, to not just go into surveillance mode, pushing and pushing. What I find is patients often have worsening anxiety and depression in this phase because it's a moment of saying, what the hell happened to me? Because you're no longer just moving to the next thing, the next appointment, the next chemotherapy, the next procedure, the next thing that's going to be done to you. It's what just happened to my life. So we need to process what just happened. I would strongly encourage you. Many of us don't want to think about it. They just want to push on to the next thing. But there's going to be that dissonance between the old life and this new normal. So take a moment to process. Realize that emotional exhaustion in the form of depression and anxiety can lead to physical symptoms of insomnia, difficulty sleeping, fatigue, and other physical manifestations. So some of the symptoms that you may be experiencing may be related to actually not taking a moment to process all the stuff that happened. So you need to sort out the toll to your physical health. The impact essentially is what I'm saying of what you've gone through. The lack of hair, maybe there's no sex drive, maybe having issues in terms of identity as a female and what that means to you and what it now looks like, the emotional and mental toll to your sexual health. So this is where I say self-reflection is key. We often encourage our patients to journal. They often resist it. But when these other physical manifestations are coming up, and depending upon how patients are talking about how they're doing and how they're struggling with life after cancer, the first thing I will talk about is do you journal? Because you may find that just giving yourself permission to write, things are going to come up that you weren't even aware of. I'd also recommend counseling. Talking to a trained professional is not the same as venting to family. We can easily become distorted in our ways of thinking, and well-meaning family and friends can play into those distortions. So it's important to seek out a trained professional, someone who has experience in talking to cancer patients, to help figure out how you're thinking about things. Patients will often blame themselves for the cancer, right? Or blame themselves somehow. Women are really good. We're really good at blaming ourselves. And so I would just encourage you, not just self-reflection and journaling, considering counseling, and then considering peer support. Groups like this, fantastic, right? Breast Cancer Coalition of Rochester, it'd be really nice if they included gynecologic cancers, but anyway, we'll talk later. But these type of community groups, right, who you're surrounded with people, other survivors, you connect with people, and so that you know you are normal and you can engage in these relationships and discussions, and it's not all new. There are others who have gone through the same thing you have and have hope. Sometimes it helps to hear that hope from others, spoken from others. But there's the Ovarian Cancer Research Alliance, National Cervical Cancer Coalition. So these are national groups that offer support groups. Cancer Survivors Network, sponsored by the American Cancer Society, Cancer Care Support Groups, and the Share Cancer Support. That's a fantastic group, particularly in young patients who have rare cancers. They really link patients together nationwide, and have found that to be incredibly useful for my young patients. So the ability to achieve a new normal sometimes requires a community, and I'd recommend reaching out. So the transition to wellness. Life after cancer really is an opportunity to adopt healthy behaviors to improve your overall health and reduce your risk of recurrence. So, we talk about this all the time, maintain a healthy diet, nutrition. What does that really mean? I'll tell you what it doesn't mean. It doesn't mean eat whatever you want and take a vitamin. Okay, that's not nutrition. What it doesn't mean, it's not fast food. It's not a lot of processed food. It's actually eating food as the way it looked, right? It would look from a garden. And so, what we recommend also is taking in small, frequent meals. Eating smaller meals and snacks throughout the day provides more consistent energy. Making sure that you're well hydrated. That does not mean Powerade and Gatorade. That's often what my patients will bring in their bottle of Gatorade and Powerade thinking that's health. I'll tell you what that is. That's fantastic advertising. Um, but Gatorade and Powerade, unless you are a supreme athlete, that is not good for you. So someone who is losing a lot of body salts by sweating profusely, there's a role for Gatorade and Powerade for the general population. Absolutely not. It is full of salt. So be careful about taking those type of things and just recognize they have fantastic advertising. What does it also mean? Weight management, right? Managing your weight, making sure that you're moving towards a healthier weight, and then being up to date with screening. Now is the time. Not seeing a primary care physician does not equate to I'm healthy, I have no medical conditions. No, what that means is you haven't been screened at all. So you probably have underlying medical conditions that would really benefit from being addressed. But instead, right, by not seeing a doctor, you say that I'm healthy. Please be careful about this is the time. See your primary care provider. Get routine screening, whether it's mammogram, colon screening, DEXA scans for bone density. Make sure you're up to date with vaccines. Do everything you can from an immune standpoint, from an overall health standpoint, to put yourself in a better situation of health. So that's primarily the transition to wellness is to think in those terms. And then incorporating exercise. And we're going to talk more about that. So let's talk about the symptom that hits probably hardest, most common symptom that we address as a team is cancer-related fatigue. So cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion related to cancer or cancer treatment, and it's not proportional to recent activity, and it interferes with usual functioning. So, treating cancer-related fatigue requires a multi-pronged approach because it needs to address what the root causes are. It may require lifestyle adjustments. It may incorporate mind-body practices and sometimes medication. But one of the key things with treatment of cancer-related fatigue is actually maintaining an optimal level of activity, which is totally counterintuitive. My patients will talk about how they're tired, and begrudgingly, I will talk about movement, how important it is. So, light physical activity is one of the most effective ways to combat fatigue. Gentle activities, such as walking, cycling, swimming, yoga, tai chi, those are recommended. Combined aerobic and resistance training can also be beneficial. But you want to start slowly and gradually increase the duration and the intensity. But I would encourage you to just start. If you're not active whatsoever, start with a 10-minute walk and then work your way up. But you may find that simple movement, right? We were meant to move, that will combat some of the fatigue that you're experiencing. The best management and strategy for addressing cancer-related fatigue, though, is involvement of all of these specialists. So palliative care, we work with palliative care all the time. And some people don't understand what palliative care is. Palliative care are internal medicine specialists who specialize in symptom management, symptom control. It's fantastic. So they are able to focus just on symptoms and addressing those symptoms, thereby improving quality of life while we, as oncologists, are addressing the cancer with chemotherapy and addressing the symptoms caused by the cancer, the symptoms caused by the chemotherapy. These physicians will address those symptoms. So we're addressing the cancer, they're maximizing, optimizing symptom control. That is a proven formula for better quality of life, both during cancer treatment and afterwards. So I often will work side by side with our palliative care physicians in my patients with cancer to optimize their quality of life. It's these interdisciplinary teams that are going to be best to tailor what interventions are needed for the individual patient. So it's personalized treatment. But I wanted to throw that out there that you understand that palliative care physicians aren't just hospice and end of life and those sort of things. They actually can truly optimize your quality of life after treatment or even during. And so, what are the drains, energy drains that patients face that often are exhibited as fatigue? So, if patients have pain, right, chronic pain, that can be mentally and physically draining. So, effective pain management is important. Emotional distress, like we talked about, depression, anxiety, they can absolutely exacerbate fatigue. So consider counseling, support groups, like we've talked about, and sometimes antidepressants. Here's my take on antidepressants. When there is a lot of stress, when you are being hit by multiple things, our neurotransmitters automatically go down, okay, as a response. And so the same activities that we were able to do when our neurotransmitters were normal, now it's a lot harder to do those things. It's a lot harder to move, to get going. And so what antidepressants do is they simply bring those neurotransmitters back to a normal level. So then we're able to do. So in these high stressful times of a cancer diagnosis or treatment, I often will recommend patients to just start an antidepressant. I recommend that you talk to your primary care provider because they're going to know all your other medical issues, all the other medications that you're on, and will know what the best antidepressant for you is. And when you get this started, it doesn't mean you have to remain on it, right? But just during this crucial time, and it doesn't mean that you're weak. That's another thing. My patients will be like, oh, I'm strong. I don't need that. I'm strong. Yes, you're an incredibly strong individual. Oh my gosh, you're amazing. But like stress hits us, life hits us. And sometimes our neurotransmitters, they go down. Like it is hard. And so just recognizing, be realistic about what's happening and seeking help can dramatically impact your fatigue and your ability to do things. So I would think about that, be open to it. It might be an option that will help. Other things like anemia can cause fatigue. So if you're anemic, that may require dietary changes or iron supplementation, maybe even a blood transfusion or erythropoiesis stimulating agent. So targeting, ruling out that a patient is anemic is key as a etiology for fatigue. Here's a big one, sleep disturbance. Poor sleep hygiene often can contribute to fatigue. And so you have to think about poor sleep environment, habits, inability to decompress before bedtime. And so I often will encourage patients to have a regular sleep schedule. I encourage them not to nap during the daytime. You really have to limit naps to less than 30 minutes. Otherwise, you'll mess up your sleep-wake cycle, your circadian rhythm. Ingesting caffeine, alcohol, high sugar foods before bed, not a good idea. Stress reducing activities really prior to bed is what you want to focus on. Reading, journaling, yoga, meditation, listening to quiet music. These are the type of things to just bring things down so then you can transition to sleep. But some of my patients will watch late night TV, they'll be on social media, cell phone use, computers. Doing that hours prior to bedtime can really interfere with sleep. Other issues, nutritional issues, eating too much, eating too little, poor dietary choices, Electrolyte imbalances, they can also cause issues. Decreased functional status, so deconditioning. Like we talked about, exercise is the most effective non-pharmacologic approach to cancer-related fatigue, and doing it with moderate intensity. So you want to exercise, if you're up to this level, exercising where you can talk, but you can't sing, okay? And engaging in resistance exercises in that fashion, and aerobic exercises really, can be quite beneficial in the treatment of cancer-related fatigue. There are also comorbidities and cancer treatment-related sequelae that may have affected your heart, thyroid, lungs, GI tract, right? So the cancer or the chemotherapy or immunotherapy affected these things. And then that can cause fatigue, that can have issues. So it would be important to seek specialists who can optimize those body systems, and so hopefully help with fatigue. There are medications such as like Ritalin or steroid course that might help temporarily with fatigue, but those aren't typically what we offer up front. So, things to really think about is just obtaining really good sleep hygiene. Counterintuitive, but all of those things, even as adults, they matter. Chemo brain. So, chemo-induced cognitive impairment or brain fog. My patients experience this all the time. And so you feel like you're not as quick as you were. The thoughts feel cloudy, difficulty paying attention, multitasking, frequently kind of forgetting in completing tasks. So if this is a situation, what I recommend is using enhanced organizational strategies, memory aids, sticky notes, note planners, or books, having habits of keeping things in the same place. So, the keys always go in this place. So even if you're upstairs, taking the time to go downstairs and put it where it's supposed to be rather than dropping it wherever you are. So getting into these routine habits will help chemo brain. It will also help your own frustration. And I always tell my patients, be nice to yourself, right? This is a time, there's a lot going on. This is a known phenomenon. So using reminder notes, using smartphone technologies, putting reminders, alarms for medications, super important. In terms of treatment wise, engaging in memory games and brain teasers, reading, learning, Sudoku, crossword puzzles, those are fantastic. That's going to keep the brain active. And cognitively active. So I would encourage those type of things if you feel like you're experiencing chemo brain. And then be mindful to do the most cognitive demanding task at a time when you're the freshest, right? When you're most energized. And so structuring your day in that way. Peripheral neuropathy, common side effect, particularly if you've experienced a taxane. And so you can develop numbness and tingling. It usually starts in the toes and the fingertips. Those are the longest nerves. And so those often will get affected first. And so it can result in numbness and of your feet, and also difficulty knowing where you are in space. And so it is super important because it can affect balance to have stability, balance, and gait assessments prior to exercise, and to have a trained professional who can help you with that balance training. Consider alternative aerobic exercises if you have issues with balance. So instead of walking, because neuropathy affects balance, consider stationary biking, or water aerobics, yoga. Use water shoes or protective footwear with exercise to minimize skin breakdown. You may not feel it and then notice. So you need to be careful and watch. Look at your skin, look at the bottom of your feet and your hands, and make sure things are intact. In terms of resistance training, you want to use padded gloves when using weights, so that you don't cause skin breakdown. In terms of symptoms, gabapentin or Neurontin and Lyrica have been shown to help with nerve-like symptoms or the peripheral neuropathy, particularly if there's a component of pain. Sexual health after cancer, right? So we talked about that this can be multifactorial. There's anatomic changes that occur after surgery. It can occur after radiation. You can get pelvic floor tightness. You can develop chronic pain. And so I love it that a pelvic PT specialist is going to be one of the speakers. But this is fantastic because patients can develop pain in this area and pelvic floor tightness that affects sexual health. We have something called pelvic PT, physical therapists who actually will teach you how to relax the pelvic floor, can identify trigger points. And so this can dramatically impact sexual health. Um, Patients who have vaginal dryness, there's benefit of moisturizers or lubricants, maybe vaginal estrogen if you don't have a hormone sensitive cancer. We talked about anxieties and worries, right, after cancer and how that can affect um, intimacy. And so getting counseling, right? Because there can be changes to body image and relationships. And what I really want to highlight also is we have sexual medicine specialists in Rochester. So family medicine, internal medicine, and even OBGYN specialize in sexual medicine. And so this is an important component, and it is dramatically affected after a cancer diagnosis and treatment. And there's help here locally. And so I would encourage you to seek that help. And then nutrition, right? If you're a patient of our practice, I always talk about protein. And why is protein so important? It's important because it's involved in the repair of body tissue and it's essential in recovery. And what's happening in cancer treatment? Cells are turning over. We're giving you chemotherapy. We're killing off the cancer. We're also affecting normal cells. That's how you get side effects. And so you need the body to repair those tissues. And the building blocks for that is protein. So it's important also in maintaining muscle mass. That has long-term side effects in terms of strength, in terms of energy, mobility. And so protein is key, and there's lots of sources. So I want you to think about your plate, just as sort of a generalization. 25% of your plate should have a protein. And you see the different protein sources. Patients always ask, what is protein? It's your fish, lean animal meat, dairy, eggs, legumes, lentils, tofu, edamame, these type of things. Um, you also want 50% of your plate to have colorful vegetables. So not just green, but orange, purple, like colorful vegetables, because these are things that have incredible wide variety of vitamins, minerals, and phytonutrients. And then you want 25% of your plate to have healthy fats, nuts, avocados, seeds like pumpkin seeds, sunflower seeds, hemp is a great source as well. So these healthy fats help reduce inflammation. Um, and then in general, if you're going to have a grain, choose whole grains. Um, but here's the caveat: whole grains have a ton of fiber. And for the general population, that's great. If you have a history of radiation enteritis or diarrhea associated with radiation, or if you have a small bowel obstruction and your bowels aren't working right, the last thing you want is fiber. And so it really depends upon your situation. Um, I see that we're running close to time. I apologize, Rachel. I got one more slide. Um, and this is really what it's all about. Life after gynecologic cancer treatment is not just a return to it's not a return to the past, but it's the start of a new chapter. We focus on health span. Health span is the quality of those years. It's not lifespan, which is the number of years lived or staying alive, but health span, the quality of those years, with a focus on physical function, cognitive clarity, and emotional well being. So, your health span, your energy, mobility, quality of life, through personalized follow up care, rehabilitation, and whole person wellness support, with the goal of you moving forward with confidence and purpose. It's not just about living longer, it's about living better. Thank you so much for your time.
That was so wonderful. I recently heard the quote that it's not just about the length of your life, but the width and the depth. And
Beautiful.
that resonated with me. So I share it with all of you. Okay, we have 4 minutes. I think we can get
Okay.
through We have 3 questions that came in. Okay, number 1. With a stage 1 ovarian cancer diagnosis and the BRCA1 gene, are PARP inhibitors indicated for longer-term treatment?
So
Neil,
that's a great question.
yeah, ooh,
PARP inhibitors really were studied in stage 2, 3, and 4 cancers. And you have to remember, PARP inhibitors are associated with toxicity, right? And the question is, with the stage 1 cancer, what's the chance of recurrence? So for those later stages, the chance of recurrence is a lot higher. So there's a benefit to maintenance therapy and potential side effects. But in stage 1, we don't know. They were not included in those original studies. So I'd have to know, what are the risk factors? Is this patient at a higher risk for recurrence? And then that would be, a really patient shared decision making to discuss if there's a role. PARP inhibitors are associated with leukemias and myelodysplastic syndrome, and those are fatal. So you have to be really mindful. If the risk of recurrence is low, maybe the risk of these other medications, outweigh any benefit.
quality of life considerations. What about aromatase inhibitors as maintenance therapies for gynecologic cancers?
Yeah, so for some of the advanced ovarian cancers with an endometrioid histology, there is a role for aromatase inhibitors, absolutely. And there's a role for hormone-sensitive cancers receiving aromatase inhibitors. We use aromatase inhibitors for recurrent cancers as well, because a lot of our patients have hormone-sensitive cancers. Um, but the actual maintenance therapy, I think, would be in the setting of ovarian, and I think an endometrioid. I think it's part of the guidelines. And low-grade serous ovarian cancer, there's a role for maintenance therapy with letrozole.
Okay. And I know that we have a program for anybody who is on an aromatase inhibitor and struggling to help deal with the side effects.
I've heard
Um,
great reviews
Thriving
of
on
that.
aromatase
Yes.
inhibitors. So let us know if you need support on those meds. Someone asked, a recent article stated that gabapentin, which you talked about for peripheral neuropathy, can increase the risk of dementia. What are your thoughts?
Ooh,
I have not
I
seen this
didn't know
article.
that. I have not seen that article, so would be very interested. All of these medications have side effects. Gabapentin, and I sort of was rushing towards the end because I realized I was getting short in time, too many soapboxes. Um, but gabapentin can cause somnolence and some dizziness.
Mm.
So for our patients, who are really struggling with peripheral neuropathy, we say take it at nighttime. But in terms of cognitive issues, I haven't seen that article. A lot of our patients, though, I don't recommend that they be on it, 3 times a day, high doses. It's one of those things that intermittently, to take it at nighttime might be reasonable.
Okay. And then lastly, what are the current survival statistics with new maintenance treatments? That's a very broad question, but I guess especially immunotherapies, you talked about how when you were starting your career, those didn't exist as maintenance medications. So have they affected the survival statistics dramatically?
Yes. Yes, a lot of these maintenance therapy, it's not just an issue of decreasing the risk of recurrence, but it's actually a benefit in overall survival.
That is exactly what we hope. Well, we are just at time, and there's always so much more that we could talk about, but I think the main takeaway is that we really hope all of you to invest in yourselves, invest in your quality of life. You've been through so much, and if you need support in processing everything you've been through, um, kind and compassionate providers like Dr. G, in addition to finding, peer support through the coalition and otherwise, we're here for you. Thank you so much, Dr. G, for sharing your time and expertise with us. And thanks to all of you for joining us this afternoon. Next week, we're going to be talking about pelvic floor physical therapy, which was mentioned as something to help you. And as we continue our weekly Wednesday webinars at lunchtime from noon to 1 throughout September and October, hope to see you all then. And ta-ta for now. Take care, everybody.
Thank you.
Bye.